Afternoon, and welcome to Ethics Grand Rounds, sponsored by the University of Colorado Hospital Ethics Committee and the Center for Bioethics and Humanities. My name is Jackie Glover. I'm a professor of pediatrics and at the Center for Bioethics and Humanities, and I co-direct the Ethics Consult Service at the University of Colorado Ethics Consult Service. And together with Julie Swaney, who is the co-chair of our ethics committee, we organize these ethics grand rounds. Welcome to all. It's great to see you. We are very fortunate to have as our speaker, Dr. Anuj Mehta, who's assistant professor of medicine, pulmonary and critical care at National Jewish Health, Denver Health, and the University of Colorado School of Medicine. He's particularly well suited to our discussion today because he is the lead of the Governor's Expert Emergency Epidemic Response Committee's Medical Advisory Groups, GMAG, and Crisis Standards of Care, and the COVID-19 Vaccine Prioritization. So he's going to talk with us this morning, and our objectives are to describe the ethical issues in the allocation of vaccines, in particular, the health equity concerns, identify the pros and cons of various allocation schemes, and describe the allocation methodology proposed in Colorado. I'm going to announce this at the end too, but please join us again on December 10th when we're going to be discussing the new public guardianship pilot that's being led by Sophia Alvarez and our own Katie Herman, who directs the social work department, and Emily McDonald are going to join her in a discussion of public guardianship pilot. So please help me welcome Dr. Mehta.
Hi, everyone. Thank you so much for inviting me to join this discussion. Thanks to Jacqueline and everyone else in the Center for Bioethics and then the Ethics Consult Service. I'm going to start sharing my screen. Can somebody just give me a thumbs up if they can see it? Okay, perfect. And feel free to interrupt me at any point if there are questions. I know we're using the chat function for questions, and Jackie can kind of direct them if we need points of clarification. So as she mentioned, I'm the lead for the Governor's Expert Emergency Epidemic Response Committee, or GERC, Medical Advisory Group on COVID-19 Vaccination Prioritization. We are a group that advises the governor and CDPHE on COVID-19 vaccine prioritization, and then they take our recommendations and modify them as needed based on implementation issues. And obviously, any type of vaccination discussion is entrenched in ethics and values. So I think this is a very apt topic, especially given the Pfizer release, press release recently. So this is meant to be interactive, so if there are questions, please feel free to interrupt. To begin, I have no disclosures. And the objectives are as stated. We're going to discuss the ethical issues of allocation vaccines, in the allocation of vaccines, identify the pros and cons of various allocation schemes. And for this, I'm actually going to present some of the ones that are out there. So less theoretical, more practical. And then we're going to describe what we've arrived at preliminarily for the state of Colorado and how we came to those decisions, and describe some of the ethical issues around health equity as related to the COVID-19 vaccine and pandemic. So some areas I won't cover, but are obviously critically important from ethical considerations are safety and efficacy, the approvals process and emergency use authorization, clinical trial design, especially with regards to minority recruitment. Global vaccine allocation is a big one that I'm not going to talk about, but has a lot of implications, and then vaccine hesitancy. And if I talked about these 5 topics, we probably would need another couple of hours. The question starts off with, why are there ethical issues with COVID-19 vaccine allocation? So in an ideal situation, you have an equal number of vaccines to those that want the vaccine. And in this case, 6 vaccines for 6 blue stick figures. Unfortunately, in Colorado, this is more often the situation where we actually have a lot more vaccines available than people that want them. Colorado does sit on the lower tier of the nation in terms of vaccine rates for flu vaccine and childhood vaccines. When it comes to COVID vaccines, the goal is to vaccinate every single person that wants the vaccine, but initially and potentially for many, many months, this will be the situation. that we'll have one dose for a whole lot of people. And the estimates vary, and it depends on which manufacturer will get the first emergency use authorization. But we've heard any estimates on the initial delivery of 10,000 doses to maybe 100,000 doses, with the total population of Colorado being about 5.7 million people, which is 1.69% of the US population. So the moment you have a resource that is critical, that where the availability is far below the demand, obviously you need to start talking about ethical allocations. And I would raise this issue that vaccines are potentially different than other types of therapies that that have been discussed from an ethical allocation perspective in the past, like ventilators or even remdesivir. So treatments are really meant to treat the primary person that's infected, but most of the treatments that we've seen, with the unique exception right now of the monoclonal antibody that got the emergency use authorization earlier this week, most treatments are instituted in the hospital once somebody's already become sick and potentially started a chain of infection. So when we treat this first person with a medication like remdesivir or put them on a ventilator, we're saving that person's life, but we're not really decreasing the spread because the person's already in the hospital, potentially. Vaccines are a little bit different, and they can decrease community spread, while therapies tend only to affect the person who receives them. And so if you vaccinate one person, you may not have that same chain. Now, there are 3 other red circles, and the red is meant to indicate those people that are infected, because these people can still be infected through other means in the community. And I don't want to create the myth that vaccines are 100% effective at arresting the entire pandemic, but really you can decrease spread. So when we start thinking about a vaccine in the setting of a pandemic, Matt Winnie actually coined the term, at least the first time I heard it, was pandemic ethics. Typically with healthcare, we think about saving the most number of lives possible. But when we start thinking about a pandemic, we weigh that as well as this idea of decreasing spread, because we may long-term actually save more lives. And that raises some additional ethical concerns that may not exist with other treatment modalities. So there are a bunch of ways that we can decide who gets the vaccine first, and we could choose a system of first come, first serve, which obviously is fraught with a lot of issues, ethical issues in terms of who has access to healthcare. We can vaccinate those who can afford it, which obviously I think that the overwhelming majority of people on this call would say that's probably not the way we should do it, that vaccine should be distributed equitably. And a lot of people of late have been arguing that healthcare is a right, not something that needs to be differentiated between different people. You can create a randomized lottery system for who should get the vaccine first. Now, you can imagine the logistical implications of that would come up in terms of enrolling an entire population in the lottery. How do you notify people? How do you deal with people that don't have adequate communications access? Or, and this is kind of where the majority of groups out there have really come to think about things, you can prioritize certain groups based on some underlying ethical principles. So there are multiple ethical frameworks that are out there, and these apply. Some of these are vaccine specific. Some of these, like the Institute of Medicine's core ethical frameworks, are more about scarce resources in general. And while they're all somewhat different, they all talk about some of the same ideas. That if we really want to be ethical in how we utilize a scarce resource, we need to be fair, we need to be transparent, we need to be consistent, we need to think about human well-being and maximizing the benefits. We want to treat people fairly, and we want to promote equity. We have a duty to care for people, but we also have a duty to steward scarce resources. And then you can see in the NASCM is the National Academy of Science, Engineering, and Medicine. They also, which I totally agree with, completely advocate for evidence-based allocation schemes. The WHO, with their unique viewpoint, raises the issue of global equity and national equity, which are not in the other frameworks, which have been much more created by US-centered groups. But that's also an important consideration and something we'll talk about a little bit towards the very end. So these are all different ethical frameworks, but they use a lot of terms that tend to mean the same thing. And so we in Colorado, in a lot of the documents ranging from the Crisis Standards of Care document that developed the protocol for hospital and ventilator triage in the event that resources fell far below demand, we kind of utilized at least the language of the Institute of Medicine from their document in 2009, and that's what's in our current set of recommendations. The fairness, transparency, consistency, proportionality, accountability, duty to care, and duty to steward scarce resources. But at the same time, there is, when you actually convert these ethical frameworks into practical ethical principles, there are some competing ethical principles. So as stated, we really, for a very long time, medicine is operated under the idea we want to save the most number of lives possible. And that really gets implemented in mass casualty settings. You know, in the terrible event that took place in Las Vegas with a shooting, or even in the military, when they're triaging trauma, right? They try and identify the people who are going to benefit from the resources the most and require urgent care. So we try and prioritize patients on the ability to save their lives. And that's something that happens a lot in medicine. Granted, typically our resources far exceed the demand, and so there's never a need to triage people. But this idea of saving the most number of lives and potentially prioritizing one person over another is something that is operationalized in medicine to certain degrees. But we also want to stop the pandemic and decrease transmission. And that, as I'll show you, may not actually be the same thing as saving the most number of lives. But the long-term effects could be to save more lives, but you won't see that immediate effect. We do need to maintain critical societal functions during and after the pandemic. If the healthcare system shut down, more people would die. Than if doctors, nurses, first responders were all to get COVID and die from that, then you would see long-standing ramifications. There's also issues of cohesion after the pandemic. If we instituted measures to that created great division within society, that can actually have long-standing impact. And there's also the question of trust in medicine, and that needs to be maintained both during and after the pandemic. The idea of reciprocity has been brought up since the beginning of the pandemic, when we started talking about ICU and ventilator triage, and now even when we're talking about vaccines, that this idea of certain people within society, not saying that one has more value over the other, but that some people expose themselves to the nature of their work. So healthcare workers, or for the case of vaccines, grocery store workers, people that are out in public due to their job. And so that's one of the operational ethical principles that we were considering. There's something called a multiplier effect. In other areas, it's been called instrumental value. I tend to shy away from that term, because this idea of some people having more value than others, I think is a misnomer or a misstatement. But the multiplier effect essentially says that some people, through their essential function, can save multiple lives. So by saving that one person's life, then there's a downstream effect. And specifically, first responders and healthcare workers are those that come to mind. And then there's also the issue of equity. And we're going to spend a decent amount of time at the end talking about healthcare equity as it applies to the pandemic. So these are some competing ethical principles. They may seem like they are all of equal value, but they can be in competition at times, and you do need to weigh them. And so when we started thinking about these ethical principles, we also started to define critical populations based on this idea that the best framework that we can use is one where we identify certain priority populations and not using a first comes first served system. And these populations are the same populations that other groups like the WHO, the National Academy of Science, Engineering, and Medicine, CDC, and others have identified, not just during this pandemic, but in many pandemics, epidemics, and other crisis situations. So healthcare workers, first responders, and public safety officers, as I've mentioned, essential workers. And so essential workers are a broad category and the definition of an essential worker is typically one that's not legislated, but issued by the government. And so a public health order from April, when Governor Polis issued a stay-at-home order, had some definitions of what were considered critical businesses, and the people that work for those critical businesses would then be considered essential workers. But we also recognize that not everybody who's an essential worker is at increased risk of exposure, and not everybody has a pandemic critical role. So there are people that are in banking that may be able to work remotely from home. It is defined as an essential function, but they might not be at increased risk of exposure. And so you'll see how this is operationalized now, in at least the Colorado framework. Congregate housing is an interesting group because it really falls into two separate categories. there are individuals that are in congregate housing, and I'm not talking about long-term care facilities and nursing facilities right now. We'll get to that in the next bullet point. But congregate housing like homeless shelters and prisons where they don't really have a choice. They're in a specific place where there's high risk of transmission and there's nothing they can do to necessarily increase their social distancing. There's also congregate housing that is that potentially individual choice can potentially play a role, such as college dormitories. But at the same time, we have seen more recently that even when there is choice, there's still these settings can be major spread to the community as well. Another critical population is individuals at high risk for severe COVID-19 disease. So these are the people that are at highest risk for dying. And the highest risk by far are those individuals in nursing homes, assisted living facilities, and long-term care facilities. The next highest group are what are considered high risk, not the highest risk. And those are our older adults over the age of 65, those with diabetes, obesity, chronic lung disease, severe heart disease. And the CDC has a list actually on one of their websites that defines what the high risk conditions are. And this is data driven. This is and would be different in a different pandemic with a different viral vector. Children and pregnant women are universally considered to be critical populations as well, and we'll talk about why that's when it comes to vaccine allocation, special consideration. So these are the critical populations that most people have talked about and that we considered in developing the Colorado scheme. And when we start putting these critical populations against those ethical principles that I mentioned, you can see that different groups hit different criteria upfront. So healthcare workers, yes, by saving healthcare workers long term, you can save the most number of lives because you're maintaining a strong healthcare infrastructure that can continue to treat sick patients. But immediately, they perform a critical societal function. There's the concept of reciprocity and the multiplier effect. And then only kind of at the end do we potentially see downstream issues related to saving the most number of lives. First responders, essential workers, there's a societal function issue and there's reciprocity. And then there's also an equity issue that we'll talk about when it comes to essential workers. And that goes along with high-risk individuals and congregate housing. So you can see that different priority populations check different ethical principle boxes. So then you kind of have to start thinking about what do you do? Sorry, there's my slide. When you have competing interests. So adults at high risk for severe COVID-19 versus individuals at high risk for spreading the virus. So what does that mean practically? Well, adults at high risk for severe COVID, we just talked about who those people might be. They might be older adults, those living in nursing homes, or those with diabetes or obesity. So prioritizing them in a vaccine scheme, you might be able to save the most number of lives. There's also an equity issue, as we'll get into, with diabetes and obesity and other comorbidities. Who are the individuals at high risk for spreading the virus? Well, as we saw in Boulder just a month ago, it's college students and other young adults that tend to live in congregate settings. And it sounds silly to think about vaccinating them first, but there's multiple papers out there that present mathematical models that if you vaccinate the people that are the primary spreaders of the virus first, the downstream effects is to potentially decrease the number of people that die. I'm not advocating that that should be the plan, but right, these are interesting potential ways to arrive at the same end of saving the most number of lives and decreasing transmission and arresting the pandemic. And potentially vaccinating people who are at increased risk of spreading the virus has the unique ability of leading to opening up the economy faster, which is not an ethical consideration, but it's a very practical consideration when we start talking about any of these allocation schemes. You can also imagine weighing adults at high risk for severe COVID versus healthcare workers and first responders. Again, so you have this issue of trying to save the most number of lives versus this issue of maintaining a critical social function. And I think that what we're seeing is that there are a lot of groups, even within the critical populations group, that you might want to weigh against each other in terms of which ethical principles are you going to be abiding by. And this was one of the toughest things that we sat around in our discussions thinking about, is how do you prioritize different groups, all of which have ethical claims to priority. So, right, adults in congregate housing versus adults at high risk. and there's an equity issue with congregate housing. They're unable to socially distance. And by prioritizing them in a vaccination effort, you can decrease the spread versus saving the most number of lives. And so these competing interests are part of the complicating features of developing any sort of scheme to think about a vaccine prioritization. I want to present a few, before we get into Colorado specific areas, I want to present a few vaccine prioritization schemes that have come out over the last couple of months. Most of them are exceedingly broad. I'll go into some detail as to what some of the practical problems are, because when we start thinking about ethical implications, though I've had the privilege of serving on the Colorado Department of Public Health and Environment's Joint Vaccination Task Force, and through them I've seen also what the reality is on implementation and how that can raise its whole own set of ethical issues. So this is from the Johns Hopkins Interim Framework from August 2020. And what they did was they broke out critical populations into two groups. This is very preliminary. We had barely even started phase 3 clinical trials at that point. So this is not what they're advocating. This was just a thought exercise that they expressed. And you can see that in there, what they would potentially put in a tier 1, you have your healthcare workers, first responders, and then also individuals at greatest risk for illness and death, and their caregivers, and then those most essential to maintaining core societal functions like your food supply workers and teachers. And I have 2 young kids, and teachers are obviously essential because they're the ones watching my kids now. And then you have the tier 2 groups that are essential workers that don't fall into tier 1. So healthcare workers that are not involved in the COVID-19 pandemic. It's hard to parse that out. Potentially pharmacy staff, those that don't have access to healthcare, so Native American reservations and isolated rural communities, other essential functions like warehouse, and those involved in public utilities, and then those with increased risk of infection, so the high density jobs like meatpacking industry. So that was kind of Johns Hopkins' proposal as a thought exercise. The CDC has published their playbook for COVID vaccination that came out. The final version came out in September, and CDPHE, where I'm working with them as well. They are feverishly submitting updates to the plan that is required by CDC with the hopes of coming close to a finalized plan by the time the vaccine comes out. So the CDC kind of broke things down into 3 phases based on what the anticipated supply is. And this would apply to almost any vaccine that eventually gets manufactured. This idea in phase 1, you would only have it in trial settings. So that's the flat portion of the blue line. And that's kind of where we are now. And then you would have a ramp up as you get either an emergency use authorization or full approval. And this is where there's very limited doses. And it's small print because I took it directly from their document, but in that phase 1A, paid or unpaid persons serving in healthcare settings, so it's important that they're calling out volunteers as well with potential for exposure. Phase 1B would be other essential workers, people at high risk of severe COVID-19 illness, including older adults. And then phase 2 would be number of doses are available. And then phase 3 is the continued vaccination where you have more than ample supply, probably more than you have people left. And this is, they didn't define every single critical population, as we'll get to in the Colorado plan, but they kind of offer this as a kind of broad view of what to expect and potentially what people should start thinking about in terms of allocation. The most robust plan was from the National Academy of Science, Engineering, and Medicine, and this came out just about a month and a half ago. And they had an interim plan, took public comment, and now published this plan. And this is also being reviewed by the Advisory Committee on Immunization Practices. They have not offered their recommendation. And the NASCM broke it out into 4 phases. And similarly to the others, phase 1 was your high-risk healthcare workers and first responders, people of all ages with comorbid and underlying conditions that put them at significantly higher risk, older adults living in congregated settings like nursing homes. Phase 2 are your essential workers and people with moderate to high risk, so people with diabetes, lung disease, obesity. And then you get into phase 3 that includes essential workers that are not necessarily exposed to increased risk of transmission. And then phase 4 is the general population. Now, one of the things that you can see in this phase, in all three phases, and these are the three big groups that are out there now, every state has been tasked with developing their own phased implementation plan, is that the practical implementation of any of these plans becomes very difficult. And so first off, in phase 1B on the NASCM plan, people at all ages with comorbid and underlying conditions that put them at significantly higher risk. The difficulty here is we don't actually know what significantly higher risk means. They've proposed that it should be people with multiple comorbidities, but we actually don't have data to suggest or that people with multiple comorbidities are at higher risk than somebody else with a single comorbidity, like say having cancer. So we don't know how to weigh different comorbidities against each other. If we go back to to this slide here, in phase 1B, we have older adults greater than 65. And what this, when you think about it on a national level, older adults or those people with any type of comorbidity that would put them at higher risk is about 30 to 40% of the population. And when you match that to the manufacturing and supply graph on the CDC Playbook, they just don't match up. And this is kind of one of those things where the ethical issues need to be viewed within the realm of implementation and the reality of how much vaccine we'll have. Because if you have 1 million people become eligible for it, say in Colorado, that's a little under 20% of our population, 1 million people eligible at once with only 10,000 doses, that is such an extreme version of limited resources that whatever ethical plan you try and implement would likely be overwhelmed by just the sheer rush of number of people. So what we did for Colorado, and this is kind of the operational plan that Colorado is using and that the GMAG came up with and then was modified at the executive level in the governor's office and with CDPHE input from an implementation perspective, is we continue the 3-phase plan, but we got very granular, which I think is the best way to ensure equity in terms of defining populations within populations. And then even within a specific phase, defining who should get it if you don't have enough. So for example, in Colorado, we, similar to everywhere else, we prioritize healthcare workers in that top tier of 1A. But we further broke it down in terms of inpatient healthcare workers and outpatient healthcare workers. And here's one, and we'll get into this when we start talking about equity. We included individuals working in assisted living and nursing facilities, as well as home health workers and outpatient pharmacists. And this was really critical because we know that in the first phase in the first surge, these were the populations that tended to get sicker more because they have the least access to PPE, but they obviously are healthcare workers providing a critical role. There is the very real possibility we won't even get enough vaccine to vaccinate all inpatient healthcare workers. And so further granularity is needed. And so we recommended consideration of those with higher risk conditions. So a healthcare worker that is over the age of 65 and continues to care for patients, or a healthcare worker with diabetes. At the same time, we recognize that there are specific teams that could potentially be at higher risk or provide a role that is just not replaceable. So the emergency department. If the emergency department lost 20% of their workforce due to COVID illness, that would potentially be catastrophic and have ramifications throughout the hospital. Intensive care unit teams, or even respiratory therapists who are potentially the highest risk because they're the ones delivering and present for all aerosolized inducing procedures. So there are different ways to provide that level of granularity for identifying critical populations within critical populations. And then phase 1B was our critical workforce. So those are our emergency medical services, first responders. And then phase 1C was our highest risk individuals of death and severe illness. So our residents of assisted living, long-term care facilities, and nursing facilities. And as we move down, we kind of continue to have expanding numbers of eligibility that we hope would match that manufacturing graph that I showed in terms of increasing amount of availability of the vaccine. And so in phase 2A, it would be a combination of those living in congregate housing, so homeless adults, incarcerated adults, adults living in group homes, with essential workers. And these are those with direct interaction with the public, like grocery store workers, teachers, childcare workers, those working in high density settings where we know that there's rapid spread, like our meat packing workers, those working in or living in high density congregate settings like homeless shelters, the people working in homeless shelters or group home workers. and also those serving a pandemic essential role. So, if somebody that's involved in vaccine or medical supply manufacturing. And then we have our higher risk individuals in phase 2B, and then our general public in phase 3. You'll see that there are a couple of people not mentioned here, and that's the note in the bottom. So children are not part of the Colorado scheme right now, because it's only recently, after we adopted this plan, that even the Pfizer trial extended down to the age of 12. So we kind of just tabled we're having discussions. We just didn't include children on this graph because we don't know where the safety or effectiveness data is going to play out. Same thing with pregnant women. There's no clinical trial right now that's including pregnant women. And then tribal members and military personnel actually have allocation through the federal government directly. So this is a very practical plan specifically for Colorado. I would call out the numbers in bold to get a sense of the scarcity that we're talking about, and why putting higher risk individuals, our phase 2B, doesn't make sense in terms of manufacturing and supply issues until we have enough vaccine to actually reach a significant portion of that population. This is the same graph, but I switched around the columns just to talk about the ethical principles that guided this, because we tried to be as consistent as possible. So when we thought about highest risk of exposure, we thought about all of those groups. Highest risk of death, that's our 1C group. When we thought about high risk of transmission or unable to socially distance, or equity, that kind of is where we came up with our 2A group. And including the critical societal function of our essential workers, and then higher risk of death for our 2B group. And we tried to find ethical principles that could be applied in a consistent way to generate our critical populations and place them in different categories. So this is actually the plan that's being implemented or developed right now. And part of the work that I'm doing is this crazy table, which is at the county level, trying to develop estimates for each one of these phases, so we can try and have proportional allocation of vaccine. Because if we get a set amount of vaccine, say for healthcare workers, and we distribute it based on the population of a given county, well, some counties have more healthcare workers, and they should potentially get more vaccine for that phase 1A group. And so this is, these are not accurate numbers, they're dummy numbers right now, but this was kind of the work that we're doing to try and get these estimates and culling data from multiple sources. The last topic I want to address is the idea of healthcare inequity. And so I think this is a really critical, I try to avoid slides with a lot of text, but this is a really critical statement that's in our recommendations. So CDPHE and this advisory group, that's the GMAG, acknowledge that longstanding systemic racism, including economic and environmental injustice, has created negative health outcomes. These systemic biases influence a person's health more than individual behaviors and affect marginalized communities, particularly people of color, more than other communities. To realize a future where all Coloradans have the opportunity to thrive, we must be leaders in undoing government policies and practices that have contributed to these inequities. And this is where I think the role of vaccine allocation comes into play, and creating new ones that ensure equity. And I think this is a really critical statement that guided a lot of our thought process. And just to kind of give everyone a snapshot of where we are, I took this from the CDPHE website today. So this is percent of cases, not hospitalizations, cases by race and ethnicity. And you can see that the percentage of cases is far below the general population number for white non-Hispanic individuals, but that far exceeds the population level, which is about 21% in Colorado for Hispanic individuals, 34.28% of all cases. And this is the hospitalizations. So one, the numbers themselves are scary because we are in an exponential phase of increasing cases and hospitalizations. But Hispanic persons account for 36.73% of all hospitalizations, and Black individuals 7.81%. That is, the Black population in Colorado is about 4% of the total population, and the Hispanic population is about 21 or 22%. And you can see the excess representation there. We did actually a lot of community engagement, which is another practical conversation about ethics, about, you know, when the metal meets the rubber, we need to actually engage with the community and find out what their thoughts are. So some groups were actually very enthusiastic about explicit prioritization of race and ethnicity. So by saying, if you belong to a Hispanic group because you are overrepresented in those that are dying or those that are getting the virus and being hospitalized, you are going to get the vaccine specifically because of your race. Other groups actually had a lot of concerns about that, about explicit prioritization, specifically around historical issues of testing without consent, such as the Tuskegee syphilis study or the Henrietta Lacks case. There's also, and JAMA has published a few viewpoints about this, there are a lot of legal issues about racial prioritization, about whether it would actually be constitutional, whether it could be a source for anti-vaccine groups to attack the plan. There's issues around self-identification, and there's obviously could potentially be issues around social cohesion. So what our conversation was, and this was echoed by the NASCM actually, was that implicit prioritization looks at issues related to structural racism rather than just race. And that potentially was a better way to view health equity in the state of Colorado. And what does that mean? Well, in developing our phases, we looked at the health equity implications at every step of the way. And this is kind of, again, where we talk about practical ethics. Phase 1A, when we start thinking about healthcare workers, and we think about what impact would that have on health inequities, we know that the individuals that work at long-term care facilities, assisted living facilities, and nursing homes have higher percentages of Hispanic or Black individuals working there than the general population. And so they're more likely to get sick, and that leads to health equities because they have higher risk of exposure to those specific communities. Similarly, home health aides on the outpatient side, more than 20% of them in Colorado self-identify as Black, non-Hispanic. And that, without the appropriate PPE or other treatments, would potentially increase the risk of exposure within that community. We also know that individuals that are healthcare providers who belong to communities of color are more likely to live in congregate settings. What does that mean? They're more likely to live in multi-generational homes with individuals who are at higher risk of severe disease. So they're more likely to live with their grandparents. Why might that be the case? There are a lot of reasons. There's cultural reasons, but we also have to think about, in terms of systemic racism, historical redlining practices that force communities of color into tighter, more highly dense communities. And so these healthcare workers are actually vectors into the community. And so by prioritizing them, you can actually decrease spread within that community. And there's actually data out of a few other countries that adequate vaccination of pneumococcal, utilizing the pneumococcal vaccine, actually reduced spread, even in those that never got the vaccine, specifically within tightly knit communities. And so there is a longstanding health equity issue around robust vaccination plans from an equity perspective. You can see in phase 2A are essential workers, janitorial staff, restaurant workers, food processors, right? They're all more likely to be belong to communities of color. And again, this is another situation where they're vectors into their community, where we know they're significantly higher spread. They tend to have jobs that are less likely to work, be able to work remotely. Phase 2B, from the high risk conditions, again, Hispanic and Black individuals are more likely to have diabetes or another high risk condition of obesity compared to non-Hispanic white populations. And so by prioritizing these groups, not because of their race, but prioritizing these groups because of their risk, we recognize that we can then potentially address some of the inequities that we're seeing. And when we go back to this slide here, specifically around vaccines, by protecting an individual who might be a vector to their community, we can actually have longstanding implications of decreasing the number and spread of disease within those communities. And I think that's a really powerful way to view health equity in a way that does not explicitly prioritize race or ethnicity. There's a lot of ongoing ethical issues related to implementation. So site selection, so say we get 10,000 doses of vaccine, that on the initial allocations for healthcare workers, that literally translates to about 11 boxes. And so which hospitals get those boxes? And then what are their responsibilities in terms of reallocating vaccine that's not given to emergency department or ICU workers to other hospitals? What types of agreements do we have? How do we choose? Do we just choose the biggest hospitals? Well, that's going to disenfranchise a lot of our smaller rural hospitals, especially those on the Western Front. Provider deserts is something that I've really advocated that we look into. So the requirements of COVID vaccination are actually quite rigid. So the Pfizer vaccine is negative 80-degree storage. The box itself that it comes in has the ability to maintain negative 80 degrees for about 6 days, but it is a logistical hurdle. There's also a lot of data requirements in terms of entering patient data into the Colorado Immunization Information Service System, CIS. So we could see that smaller practices that would say typically provide flu vaccine may choose not to provide the COVID vaccine, and this could potentially disproportionately affect access to communities of color. And that's actually something we're working on now, is trying to identify where are there a lot of influenza providers, but not COVID vaccine providers that are signing up for our system. Storage issues, I talked about the negative 80-degree storage. That's something that's obviously been in the press a lot, and we're considering how differential access to negative 80-degree temperature could have ethical implications. Patient identifier, so this is a big issue. The CDC was requiring every single patient that gets a COVID vaccine has to be entered into a database for tracking. Typically, that data is stored locally, potentially would get transmitted to the state in a de-identified way. The CDC has mandated that patient identifiers be transmitted all the way up to the federal government. Colorado has taken a stand that that's not something we want to do, and so we are resisting signing the data use agreement, but you can imagine the ethical implications and potential real practical ramifications on communities of color if they felt that their information was going to federal partners. There's ethical issues related to institutional mandates. So we have a statewide mandate to institutions for 90% flu vaccination rates. What does that mean for COVID? What would happen there? Those conversations have not even begun to happen, but what are people's rights to opt out of that? And then vaccine hesitancy is another huge issue that has ongoing ethical implications in terms of how we message vaccine safety and efficacy. So that's the end of my talk. Kind of rapid blitz of ethical issues that affect a variety of vaccine allocation implementation perspectives. This by no means is the only issues that are there, but these are some of the biggest issues that came up in designing a system and now trying to really, really implement it with actually only partial data, since we don't even have any data from the trials. I've heard folks in the public health world comment, it's like we're flying a plane while we're still assembling it. And it's, there are a lot of amazing people at CDPHE, amazing people in the governor's office and GERC and my own physician colleagues who have been actively involved in this that have been doing some great work that I think within 4 to 5 weeks is going to come to fruition. And we'll actually have to start implementing this plan. So happy to take any questions. Hopefully I can stop talking and this can lead to a good discussion.
Thank you so much, Dr. Mehta. That is just excellent. And I've been monitoring the chat, and I think I have called out what I think was already answered. So, but the first one that has come up several places, where do people with disabilities fit into your schemata, please?
That's a great question. And there was actually a New York Times article that came out most recently, I think it was a couple of days ago, suggesting that individuals with developmental delays potentially have higher risk of death. So the difficulty right now is that that data hasn't been vetted. So if you have a disability that puts you in a group home of any sort, which is the minority of individuals with disabilities in Colorado, then you would be in 2A. If you have a disability that makes you at higher risk for like a comorbidity, so we know certain disabled populations are more likely to have diabetes, more likely to have obesity, that would put you in 2B. We want to be as data-driven as possible, though, and so the New York Times article cited a private database that was reviewed by one person and has not actually been peer-reviewed and has not been published anywhere. But it's something we're closely following because I think we want to be as data-driven as possible. And if we identify specific populations that have higher risk of severe disease, we would try and include them in that 2B group. Yeah.
Thank you very much. Does it get so granular that someone who already carries antibodies would not get a vaccine?
That is a fantastic question. So that's actually been discussed at, I think, a lot of, at the national level. ACIP is considering that right now. And there are some ethical reasons to consider that somebody with antibodies may benefit less. So you want to obviously maximize the benefit of any intervention that we're going to provide. But the reality is that, one, the logistics of like you have to have your antibody titers. How soon before you get the vaccine, you get them drawn? Are they from 3 months ago? So we anticipate that they're going to disappear in the next week. Are they from the day before? Are they neutralizing antibodies? There's a lot of issues with that. Not only the fact that people have to, present and prove their HIPAA protected data to say yay or nay. And so I would think that that's probably not going to end up in the overall implementation scheme, more from a logistical issue. And also this idea from an ethical perspective of they may not benefit as much. We don't know that. We have no idea if having antibodies actually from disease or from exposure prevents you from getting it long term and the timing of those. Because right now antibodies are given as a positive or negative. We're not really doing titers on a clinical level.
Dr. Mehta, given Colorado's history with vaccine hesitancy, any projections on the percentage of people that will, in each of these categories, that will indeed decline?
So I'm not an expert on vaccine hesitancy. I've chatted with some people who are at the University of Colorado. They think in reality, when push comes to shove, that we'll see less vaccine hesitancy for COVID than we will for others because of the critical importance in reopening society. That being said, in some communities, we're hearing reports of as high as 50%, which again, that's kind of where we are for flu vaccine. But I think that's it's sobering. I think the really important message I heard recently, and something that I've been engaging with people a lot about, is that there's a growing sense of healthcare worker hesitancy. And that's something we don't typically talk about. One, because flu vaccine, you're required to get it unless you have a documented excuse. But right, with all the politicization of the vaccine process, there's been a lot of concerns about safety, which is different than the anti-vaccine group. I think these are, legitimate, smart people thinking about reasons they may want to wait. So we're trying to address that. I think the fact that the first vaccine data came after the election rather than before it, supports the fact that it's less politically motivated now. So,
healthcare workers that live in one county, work in another.
Whoever had that question just raised one of the biggest issues we had on a practical level. So, all employment data that we utilized is based on where you work, not where you live, which could be different than where you obtain healthcare. And all the comorbidity data that we utilize is based on where you live. And so the numbers don't actually add up. Sometimes when we got to that phase 3 in terms of estimating a county population that was left, we had negative numbers because of that. More people work in a county than live there. That being said, the majority of healthcare workers, especially inpatient healthcare workers, will get vaccinated where they work, and that's kind of how we're going to distribute it for outpatient healthcare workers. A lot of people work for large institutions, and they'll be told where to get it. For the smaller, like individual practice and things like that, we're having some good discussions right now about how different hospitals can take on that responsibility. So if you work in a private office, you can go to this hospital to go get your vaccine, or local public health authorities.
You had right up to the minute data. Where do people get right to the minute mortality data? The
CDPHE website, covid19.cdphe.gov, or just Google COVID-19 CDPHE. Their website's fantastic. They updated it about a couple of months ago from a very clunky system to something that the data is much more easily accessible.
How about misclassification? It's self-identification, but especially for Indigenous people.
Yeah, so misclassification, everything's going to be based on self-identification, including that essential worker status. If you're a grocery store worker, most people at Whole Foods, I don't think, have ID badges. So this is where trust, right? We have to remember we live in a society. We have to work together to get through this. That's what mask wearing, that's what socially distancing, or what CDPHE is now calling it, transmission control. So if you see any of their slides and you see TC on it, that's transmission control, which is another term for social distancing. So you need to, we just need to trust that people are going to self-identify properly. Now, we do know that the tribal authorities in Colorado are likely to get, actually they've decided to get the vaccine through their IHS system, which is a different supply than that's coming through the state, but that doesn't mean we're going to exclude them. So if a tribal member shows up to a private practice outside of the reservation and says, you know, I have diabetes and we're in phase 2B, you know, they should still be vaccinated. We're not going to block anybody.
It's coming in fast and furious now. Phil mentioned a story on CPR about a doc in a rural setting. How are we going to handle rurality? Because if the one doc goes out, it has really downstream implications.
Yeah, so that's an issue both from a perspective of how do we get the vaccine to those recipients, but then how do we also position the vaccine so that people that live in those communities can get it. So in the initial sites, even from a healthcare perspective, there's been thought about regional distribution. So not just strictly based on proportionality, we're talking about making sure we have geographic diversity in terms of where the vaccines are pre-positioned. Then it also becomes this idea of, we know that certain local public health authorities have a very large encashment area. Some areas may have like mobile vans to provide vaccine, but you know, those cost $175,000 to set up, and not everyone's going to have that capability, especially with a negative 80-degree system. So there's a lot of holes in the system, and some people will need to actively travel to go get it in phase 1. When we get to phase 2, that's a little bit of a different story. That's when individual providers can start getting vaccine to give to their patients. And importantly, retail pharmacies like CVS, Walmart, Walgreens, and individual pharmacies will be able to have vaccine. And that actually, I think, will you know, reduce the distance that most people will have to travel to go get it.
How about the people who are non-compliant with masks and things and get COVID? Is there any role for that? And some people think this is just exercising your constitutional right.
We have a lot of discussion about, I think a lot of people on this call are healthcare workers, not everybody. We have a lot of discussion in our ethics conversations about the moral distress that causes. And I think that burnout, moral distress, anxiety amongst healthcare workers is, me included, is reaching an all-time high, and you know, what's coming in December is truly frightening. But at the same time, you know, somebody that I think it was an ER episode where somebody who committed a mass shooting came in, and they still treated him because that's what we signed up for. So when people don't wear a mask, as much as I'm annoyed by it, as much as I recognize that it potentially affects me and my family, you know, I'm allowed to be annoyed, but I also have the moral obligation to continue to treat them. And I have to remind myself of that sometimes. But same thing from a vaccine perspective. Actually, there's some arguments actually that those people should be vaccinated first because they're more likely to spread it, but that's, you know, not something we want to operationalize.
Dr. Mehta, any thoughts about how to send out mass public communication about vaccine arrival with limited distribution while maintaining institutional integrity?
Right now, I think it's really hard because we don't have any data. So the only data, which is very promising from Pfizer, came out in a press release. I think the pandemic has changed us from peer review to press release and preprints, which is problematic to say the least, because the press release from Pfizer was 3 paragraphs. And now we're saying 90% and everyone's gung-ho about this. And potentially, if everyone thinks the vaccine's around the corner, could reduce mask wearing and transmission control or social distancing. So I think we need to be careful about how we message, but I think that once we have the data, the important thing will be to highlight the safety and efficacy. And I think one of the biggest things that people are concerned about in terms of vaccine hesitancy is the speed with which the vaccine was developed. And that's something that I hear over and over with all the community engagement. We talk about how it typically takes 10 years. Let's pat ourselves on the back that we did it in less than a year. And that potentially makes some people afraid that, you know, it wasn't done safely. And while I can't speak to the specific drug development, I do draw the analogy that while it may take 2 years to build a skyscraper in downtown Denver, if you hired every construction worker in every construction company, it can be done safely in 3 to 6 months. Those are my made up numbers, but that makes sense. This is one of those few times where almost every single pharmaceutical company has been working hard in conjunction with science partners to develop a vaccine. and more resources have been thrown behind this. So it's not surprising that it has happened faster. And hopefully our drug discovery in general is happening faster than it was 2 decades ago. So I have some faith in the process, and now I just want to see the data.
So I thought you answered many of the nursing home questions, but I want to make sure that I'm not wrong about that. One question about you have to vaccinate nursing home residents if you vaccinate the staff as well. And the other one was the nursing home employees are also minority populations, and I thought you addressed that very well. And the final one, how about nursing home? How do you vaccinate nursing home employees that have travel restrictions?
Mm-hmm. I'll deal with the nursing home employees first and recognize this applies to all long-term care facilities and assisted living facilities. So they're in our 1A group, right? Because the residents of nursing homes are not going to King Soopers to get it. They're not getting their COVID from King Soopers. They're getting it from the employees that are coming in from home, not because the employees are not doing exactly what they're supposed to, but that's the only way it's entering into these areas. They provide an essential role. So we thought it was really important also from an equity perspective to put them in 1A. The actual question of how they get vaccinated is one actually that we had a meeting about yesterday. And we have the head of one of the bodies representing long-term care facilities helping us through this. And it would likely be partnerships with hospitals, so the employees can go to a hospital to get it, or with local public health authorities. And we actually have a list of every single nursing home in the state. That's how we're trying to operationalize it. Phase 1C is for the residents themselves. And the federal government has actually developed a partnership with Walgreens and CVS. Walgreens and CVS, every nursing home long-term care facility has the option of partnering with Walgreens and CVS, and where they will send workers into the nursing home to vaccinate the residents and then send them back for the second dose. And individual nursing homes can choose to partner with individual pharmacies if they have a pre-existing relationship, which in Colorado, I think it's been about 15 nursing homes that actually chose that option. Everyone else is going to go with CVS and Walgreens. And so that actually reduces the burden on local public health authorities.
Final question. This has been great. Can you speak to the implications of the difference in this vaccine? It's a mRNA vaccine that's different than the others. Does that have any implications?
So Pfizer and Moderna's vaccine are mRNA vaccines. We've never had an mRNA vaccine in humans used, especially en masse in the past. So that does raise additional safety questions. I think that efficacy is measured the way efficacy is measured, but it raises some questions about how do we do long-term follow-up. We can't delay the vaccine. This is another ethical question. We could easily delay the vaccine for a year to do 1-year follow-up, but then you have to count the number of people that die because of it. For an EUA, the FDA actually, after much rigmarole and attempts of blocking it from the White House tried to block these regulations, instituted 2 new regulations around emergency use authorizations for a vaccine. One is that 50% of participants have to be followed up for 2 months after the second dose of the vaccine. And based on all other data, 95% of vaccine adverse events happen within 6 to 8 weeks. So 2 months, 2 months of follow-up is pretty good for an emergency use authorization, totally different for full approval. I anticipate that the majority of people have completed about 6 months of follow-up. That doesn't preclude long-term issues 1 year, 2 years out the road, but then you have to start weighing how long do you delay something that could potentially save lives to see what would potentially be a very low rate of adverse events. I'm reminded of the numbers from the swine flu epidemic and Guillain-Barré syndrome in 1970. The incidence of Guillain-Barré was 1 in 100,000. No clinical trial will ever include 100,000 participants. If we have an adverse event rate that is greater than 1 in 50,000, actually technically 1 in 25,000, none of these clinical trials will pick it up. And that's an unfortunate reality of trying to do science, but also not delaying effective treatments. You have to weigh those 2 things constantly. So I think we have to have really good long-term follow-up, really robust phase 4 trials, something we don't talk about very often, which are that kind of post-approval monitoring. And that's why all of these trials are 24 to 36 months. So even after approval, they will continue to follow the original participants.
Thank you very much, Dr. Mehta. This has been recorded, available on coloradobioethics.org. Hope to see everyone or many people next month, December 10th, for a discussion of the public guardianship pilot in Colorado. Thank you all for joining.
Thanks, everybody. Stay safe over the holidays, wear your mask, socially distance, all the important things we need.
Excellent. Bye.